Hello guys, Assalamu alaikum. How are you all? OBGY, gynae doctors and students. I hope you people are enjoying good health. This is me, Dr. Asma Ali, and today I am back with another hot topic of your exam, that is thrombocytopenia in pregnancy. As you know all that thrombocytopenia in pregnancy has got a lot of causes, and one of the most important of these causes is the topic which we are going to study today. And the topic I have for that is alloimmune thrombocytopenia in pregnancy, which is also called fetal and neonatal alloimmune thrombocytopenia. So this is important exam high yield question. It can come in the form of your static station, EMQs, or single best answer MCQs. So listen and watch carefully. So, what is AIT or alloimmune thrombocytopenia? It is the most common cause of severe fetal and neonatal thrombocytopenia and of intracranial hemorrhage in term neonates. So, you can see that it affects 1 in 1,000 pregnancies, an unlikely hemolytic disease of the fetus and newborn, which is also the RH incompatibility topic. It approximately 50% of the cases of fetal-maternal or alloimmune thrombocytopenia occur in first pregnancy. So kindly remember this. This is very important point for you all. Now you can be asked that what it is, right? Like what is the pathophysiology of this condition? So it's very simple. Alloimmune thrombocytopenia in pregnancy, it happens when a mother's immune system makes antibodies against the fetal platelet antigen. Please note, here the mother immune system is attacking the fetal platelet antigens which the fetus has inherited from the father, causing the baby's platelet to be destroyed by the mother antibodies and leading to low platelet count, that is thrombocytopenia in the fetus and or newborn, and a risk of severe bleeding. Even intracranial hemorrhage can occur in the fetus and baby as well. So this is a beautiful diagram that is showing how the pathophysiology of fetal neonatal alloimmune thrombocytopenia occur. As you can see here, this point is showing that the fetus has inherited paternal platelet antigen, most commonly HP1A, that is usually absent in the mother, but the fetus has got that antigen. So maternal immune system create antibodies, HPA1A antibodies against those antigens of the fetus, and these antibodies then crosses the placenta and then they attack the fetal platelet cells. So after crossing the placenta, entering into the fetal circulation, the antibodies attack and they destroy the baby's platelet, causing low platelet counts, and the baby becomes a temporary bleeder. And if the condition is severe enough, bleeding is severe enough, the bleeding can occur in the neural tissue, causing disability or even death of the newborn baby or even the fetus. So the most common platelet antigen implicated in this condition are HP1A, which accounts for 80% of the cases. So this can be your question. And another less important antigen is the HPA5B, which accounts for only 15% of the cases. So this whole slide is very important for you all. Next, you can be asked that what is the risk and complication of this condition. So mostly the risk is mostly for the baby. The most severe complication of this condition is intracranial bleeding, which may occur in utero or even after birth or during birth even. This complicates 10% of the cases and often result in death or long-term neurological damage. So you can be asked that how much is the percentage of intracranial bleeding or intracranial hemorrhage complicating the pregnancy that is suffering from alloimmune thrombocytopenia. So what about the mother? Is there any risk to the mother or complication regarding this condition? No. The answer is no. Usually the mother is asymptomatic. She is absolutely fine. There is no history of any bleeding disorder in the mother. But the main concern is that the mother carries risk for future pregnancy. So with each pregnancy, the mother is carrying a risk for recurrence of this alloimmune thrombocytopenia condition. So what are the symptoms in the fetus and newborn? The symptoms, usually the baby could be or the fetus could be silent, but it can appear as in the form of easy bruising, petechiae, purpura, or severe internal bleeding. So how you are going to diagnose this condition? The diagnosis requires the demonstration of what? Maternal platelet antibodies that react against the platelet specific antigens present in the father and neonate but not in the mother. So the diagnosis is simple, that we have to take 3 types of sample. 1 from the mother, 2nd from the father, and 3rd from the fetus or neonate. So when we compare these things, the maternal platelet antibodies would react against the antigens that are usually present in the father and neonate but not in the mother. Please note. So the sample therefore need to be sent from both the parents and the neonate for the transfusion laboratory. Okay? So what about the management? In a term healthy infant, what we have to give? We have to give HPA negative platelet transfusion to maintain the platelet count more than 30 into 10 raised to power 9. So please note that this is category of term healthy infants. And if you are asked that what about the platelet in presence of bleeding or in preterm infant, so the answer would be the platelet should be kept higher at 50 into 10 raised to power 9 per liter in the presence of bleeding or in preterm infant. So the platelet should also be irradiated and CMV negative. Plus you have seen that it should be HPA negative. Please note, this could be your important question. So what are you going to give information to this couple, or how you are going to manage any pregnancy of such kind of mother who has history of baby suffering from intracranial hemorrhage, and the management of subsequent pregnancy, how you are going to counsel, how you are going to manage this couple. So the important thing you have to note that the rate of recurrence in subsequent pregnancy is 75 to 90. So you can see that this is a big chunk. And with each subsequent effective pregnancy, the thrombocytopenia usually occur earlier in gestation and unfortunately tends to be more severe. So the risk of intracranial hemorrhage following a previous pregnancy of FMAIT with intracranial hemorrhage is estimated to be around 70%. So this gives a bad emoji, because you have to be careful that if a mother gives history of intracranial hemorrhage in her previous baby, so in this pregnancy you have to be very careful, because the recurrence of intracranial hemorrhage can be around 70%. So this picture I have taken from your textbook, and it shows how is the risk of feto-maternal alloimmune thrombocytopenia in the subsequent pregnancy. So they have categorized the risk to the fetus in the form of 3 types: standard, high, very high. When you are going to call that the risk to the fetus is standard, when the history of older sibling, mean the history of the previous pregnancy fetus, that the baby was suffering from neonatal thrombocytopenia, but that sibling had no intracranial hemorrhage. When the risk to the fetus is high, when the patient is giving you history that intracranial hemorrhage occurred to the previous pregnancy baby only in 3rd trimester, mean that intracranial hemorrhage occurred late in the pregnancy, in previous pregnancy. So what is the risk to the fetus? When we are categorizing the baby, very high at risk of having feto-maternal alloimmune thrombocytopenia, when patient gives history of intracranial hemorrhage occurring in the previous baby, newborn, occurring before 28 week of gestation. Mean when intracranial hemorrhage occur in the previous baby earlier in pregnancy. So that baby in this pregnancy is going to have a very high risk of intracranial hemorrhage again. So how you are going to manage the antenatal care of the patient in current pregnancy if she present to you in this pregnancy with a history of intracranial hemorrhage or history of alloimmune thrombocytopenia in the previous pregnancy. So prevention is better than cure. So in mother with previously delivered newborn with alloimmune thrombocytopenia, this pregnancy needs strict follow-up. How? Because 10 to 20% of cases can develop ICH, intracranial hemorrhage, and of which 50 to 70% seen in utero only. So what are you going to give to the mother? This is your exam question. That maternal treatment or management includes giving intravenous immunoglobulin in the range of 1 to 2 gram per week per kg. Okay, so it is 1 to 2 gram per kg per week, plus minus, mean you can add or you cannot add steroids in the form of prednisolone, and the dose could be 0.5 to 1 milligram per kg per day. So when you are going to start the intravenous immunoglobulin for the mother, the intravenous immunoglobulin may be started weekly at 12 or 20 weeks of gestation till 26 weeks of gestation. Or you can carry on this management till 3rd trimester as well. And what about the mode of delivery to prevent the baby from intracranial hemorrhage if the baby is suffering from alloimmune thrombocytopenia? The best mode of delivery for this fetus is elective C-section to avoid intracranial hemorrhage. So the intrapartum management of a patient in this pregnancy having a history of neonatal intracranial hemorrhage in the previous includes that the optimal route of delivery, however, vaginal delivery is considered safe if the fetal platelet count is more than 100. So this could be your question. In cases where the fetal platelet count is less than 50, the options are to perform a C-section or allow normal vaginal delivery within 5 days of an intrauterine platelet transfusion. So if the fetal platelet count are less than 50, you have got two choices. One choice that you can perform elective C-section, or second, you can go normal vaginal delivery within 5 days of intrauterine platelet transfusion. Mean first you have to give intrauterine platelets to the fetus, followed by within 5 days opting for a normal vaginal delivery. So if the fetus is to be delivered vaginally, you have to keep some important points in your mind that can be asked in your viva, in your EMQs, that what precautions you are going to consider while the fetus need to be delivered vaginally. So the trauma should be minimized with avoidance of ventouse, mean you are not going to apply any vacuum, you are not going to apply any rotational forceps, and scalp monitoring and fetal blood sampling. These all are avoided in term to avoid the trauma to the fetus, because we have to protect the baby from the intracranial hemorrhage. So at the end I am going to give you one line exam punch that alloimmune thrombocytopenia presents in the first pregnancy. You have to note this point, with normal maternal platelets and carries a high risk of fetal intracranial hemorrhage. So this is your one line exam punch. A scenario can be around these 3 lines. So now I am going to give you a gift slide, and the gift slide is in the form of a clinical scenario that can be asked in your exam, and you have to remember these points which I have just mentioned. So I have a clinical scenario that a 26-year-old antenatal patient at 28 weeks of gestation presents for a routine antenatal care. Her pregnancy has been uncomplicated so far. She has no history of bleeding disorder and her platelet count is normal. So you have got a good point. She gives a history of her previous baby died on day 2 of life due to intracranial hemorrhage, and the record of her previous pregnancy shows that baby had suffered from severe neonatal thrombocytopenia and no cause was identified at that time. So now, if you are going to give this scenario in your static station or interactive station with the examiner may ask you such questions. And the question could be, what is your likely diagnosis? And the answer is none other than fetal and newborn alloimmune thrombocytopenia. Then the examiner can ask you that why do you suspect this condition? And you have to answer that the mother is having no history of bleeding disorder, her platelet count is normal, and she gives history of her baby in the previous pregnancy suffering from severe intracranial hemorrhage that led to the death of the baby on day 2nd of life. Okay? So what is the pathophysiology? We have just gone through that. How you will manage this pregnancy and mode of delivery? So you have to given the answer that in this pregnancy we are going to give this patient weekly intravenous immunoglobulin plus minus prednisolone as well. And the mode of delivery, ideally to save this baby from again the same happening, that is intracranial hemorrhage, we can go with elective C-section. Okay? So the neonatal management, again, it depends upon the platelet count in the baby. If the platelet count is less, you can give HPA negative, irradiated and CMV negative platelet transfusions to the baby. So that's all from me. I hope you have liked this topic and you can remember this. And this thing is very important. You can get it in your, again, the same thing that you can get it in the form of SPA, EMQs, static station, interactive station as well. So that's all from me. Thanks for watching and follow my channel for more informative videos from my side. So take care. Bye. Allah Hafiz.